Hi, my name is Caden Tynstra, and I'll be presenting our project, Reevaluating Antifungal Treatment Duration for Histoplasmosis in Immunocompromised Patients. This was a retrospective cohort study done with Dr. Barros and my colleague Clayton Hicks in the Division of Infectious Diseases at Indiana University School of Medicine. Histoplasmosis is a fungal infection that causes substantial morbidity and mortality in immunocompromised patients. The Infectious Disease Society of America guidelines recommend at least 12 months of antifungal therapy, but that recommendation is based on limited data. Prolonged therapy comes with important downsides, including drug toxicity, adherence challenges, and financial burden. That brings us to the key question of this study. Is shorter therapy adequate, or does it lead to worse outcomes? Our primary objective was to evaluate whether shorter antifungal therapy, defined as less than 1 year, is associated with worse outcomes compared to the guideline-based approach of at least 1 year of therapy. We also had secondary goals, specifically to explore all-cause outcomes and to examine prognostic markers such as antigen burden and the timing of symptom onset at diagnosis. We conducted a retrospective cohort study across the IU Health Hospital system. We included immunocompromised adult inpatients with proven histoplasmosis and excluded outpatients or those with incomplete treatment data. That left us with 98 patients. The exposure with treatment duration, less than 1 year versus at least 1 year. The primary outcome was histoplasmosis-related composite of death, relapse, or repeat hospitalization. Our secondary outcome was an all-cause composite, which included those same events for any cause. We adjusted for demographics, type of immunosuppression, disease severity, CNS involvement, antifungal regimen, antigen level, and symptom onset. To minimize bias, we used inverse probability of treatment weighting with gradient boosting and assessed balance with standardized mean differences. We then performed weighted logistic regression, Cox proportional hazard models, and Kaplan-Meier survival analyses. Here are the baseline characteristics. Before weighting, amphotericin use was more common in the longer treatment group, but after IPTW adjustment, covariates were well balanced, with all standardized mean differences less than 0.1. This love plot shows the covariate balance before and after IPTW. After weighting, all covariates were reduced to less than 0.1, confirming adequate balance between treatment groups. In both a weighted logistic regression, shorter treatment was associated with higher odds of both all-cause and histoplasmosis-related outcomes, though neither result reached statistical significance. However, the direction of effect consistently favored longer therapy. In exploratory for the logistic regression models, we also found that antigen burden and symptom duration were important signals. Patients with moderate antigen burden had significantly lower odds of adverse outcomes compared to those with very high levels, and patients diagnosed earlier, within 30 days of symptom onset, were also less likely to have events. Our Cox models told a similar story. In unadjusted analyses, shorter treatment was associated with a significantly higher hazard of all-cause outcomes, but after IPTW adjustment, this effect was attenuated, with a hazard ratio of 1.7 and a p-value of 0.06. Histoplasmosis-related outcomes did not differ significantly. Looking at Kaplan-Meier survival curves, we see that event-free survival was significantly worse for all-cause outcomes in the group treated less than a year, with a log rank p-value of 0.049. Histoplasmosis-specific survival, however, was similar between groups. When we looked at outcome frequencies, all-cause rehospitalization stood out. Patients treated less than a year had significantly higher rates of all-cause rehospitalization. Relapse and mortality rates, however, did not differ significantly. Histoplasmosis-related outcome frequencies were not significantly different between the groups. To summarize the findings, shorter antifungal therapy was associated with worse all-cause outcomes. Histoplasmosis-specific outcomes were underpowered and did not show significant differences. These results support the current guideline of at least 12 months of therapy. However, one of the most important insights from this project is that not all patients may require the same treatment duration. In our exploratory analyses, antigen burden and the timing of symptom onset at diagnosis emerged as promising markers. Patients with lower antigen levels or a more indolent subacute presentation may have less severe disease and could potentially be treated safely with shorter courses. On the other hand, patients with high antigen burden or rapid symptom onset may truly benefit from prolonged therapy. Our study couldn't fully answer this because of sample size, but it lays the groundwork for future risk-stratified approaches. If validated in larger studies, these markers could help tailor therapy, minimizing toxicity and costs for low-risk patients, while still protecting those at higher risk of relapse or death. Of course, residual confounding remains possible. Factors like adherence and intensity of follow-up may have influenced outcomes. And our retrospective single-center design with modest sample size limits generalizability. So in conclusion, for immunocompromised patients with histoplasmosis, guideline-based therapy of at least 12 months remains the safest approach. However, there is an opportunity for future studies to refine who may safely stop earlier and avoid unnecessary drug exposure. Thank you.